Okay, welcome back. This is the second part to this LRA 110. We're entering now into the study of arthrology. And again, arthrology is the medical term for joints. It's a study of joints or articulations. So we go back and forth with these terms, and I just want you to make sure that you become familiar with both joints or articulations, and they're both called arthrology. So we need to know that it's important to understand the movements of that occur in all joints. And so we're going to look at classification of joints first. So we want to look at the structural part first. We need to understand that there are three different types of structure, how they're classified by their structure. And the primary classification system of joints described in Gray's Anatomy and is also used in this textbook is based on the three types of tissue that separate the ends of bones in different joints. So these three classifications by tissue type, along with their subclasses, are as follows. So we have fibrous joints. These are held together by fibrous tissue. And then we have cartilaginous. And then and these are held together by cartilage. And then we also have synovial joints. And these are, again, classified as synovial because they have synovial fluid in a in-joint capsule. If we look at, I'm going to start off with fibrous joints. And fibrous joints, we have also the function, which is the next category. They can also be classified by function. So most of these fibrous joints are going to be synarthroidal. Not all of them, but some of them are going to be synarthroidal, which is, when we refer to them as synarthroidal, we're talking about their function, their movement. And synarthroidal would be immovable, right? These joints don't really move. There's an articulation there, but they don't move. The other one is cartilaginous, and this is amphiarthroidal. The function, amphiarthroidal, and these have limited movements. The other one, the synovial, are considered to be their function to be diarthroidal or freely movable. All right, so this one we're looking at the types of fibrous joints that we have in the body. And we have underneath fibrous joints, we have syndesmosis, again, which is slightly movable. We have this type of joint, for example, down in the ankle area. We also have it by the wrist. Well, not in the wrist, but in the radius and ulna articulation. And again, just so that we can know that this fibrous joint can be found in these distal ends, and we consider them to be slightly movable. So this would be syndesmosis, amphiarthroidal. Then we also have, and by the way, these joints here, this articulation, they're held together by interosseous ligaments and slender fibrous cords that allow slight movement at these joints. Like I had said, that you find these in the tarsal area down towards the ankle, also by the radius and ulna, and they can be syndesmosis. The other type of fibrous joint that we find is found in these sutures of the calvaria of the skull. So these sutures, again, because these are bones that come together, this is also an articulation or a joint. And this one's a little bit easier to remember because these are considered synarthroidal. So this type of joint It's a fibrous joint. It's a suture type of joint. And these are synarthroidal. They don't move. They're considered immovable. And in the last category for fibrous joints, we find gomphosis. And gomphosis is amphiarthroidal, meaning that there is some slight movement here, and this can be found in the roots of the teeth, right? What pulls our teeth down, right? So we have an articulation here, and it has limited movement, right? You can consider when people have braces, they're put in there, right, to correct um, how the teeth are aligned in the mouth. And so it does allow for some correction. And so that's called gomphosis, and it's a fibrous, um, classified as a fibrous joint, and it does have limited movement. So it's amphiarthrodia. Alrighty, the second type would be cartilaginous joints. These are fall into two different categories, which is either symphysis or synchondrosis. Cartilaginous joints in the classified under symphysis, we're going to consider the symphysis pubis of the pelvis. And this is where one of both alas and the ischium and the ramus come together and join right at the center. So this is considered fibrocartilage, right? And we do have slightly movable, um, uh, which is considered amphiarthrodia, right? The function would be amphiarthrodia because there is some slight movement here in the pelvis area. This is what moves when we walk, when we run. This slight movement helps us to be able to do that. Now, we don't want full movement, right? Because then we wouldn't be able to hold our balance and so forth. In the vertebral body, we also find this cartilage, fibrocartilage, on here, and we also consider that to be amphiarthrodia. So we do have some movement, but it's very limited. This is the area on the spine where, especially in the lower back, you hear patients complaining of having a slip disc, which is the correct term for it is uh, the correct term for it would be a herniated nucleus pulposus. Herniated nucleus pulposus, and this is when trauma perhaps was caused in the lower back, and this cartilage is sort of herniated and it kind of protrudes out, and the I'm going to try to right on here, the vertebra will slip forward, and then this will become sort of bulging out, kind of like a balloon when you squeeze it, and it becomes herniated. So that's a herniated disc or a slip disc, but the correct term is a herniated nucleus pulposus. You'll learn about that later. The other one, which is what we were looking at, bone growth. Remember I told you that there's some cartilage in the epiphyseal plates here for pediatric patients. This one is also part of the cartilaginous category, but these are synarthroidal, immovable, right? So this cartilage stays in place. It eventually, like we said, disappears when it goes through through ossification, endochondral ossification, and so it slowly will disappear during endochondral ossification. Let's look at the next category. This one is the one that we have most of. This is the synovial classification of joints. Again, we said that most of these joints are their function. They're generally generally freely movable, or we consider them to be diarthrodia. That's what diarthrodia means, right? Freely movable. And these joints will have a fibrous capsule that contains synovial fluid. And this is a unique characteristic to this type of joint. And you have a fibrous capsule here. You have accessory ligaments that kind of hold it in place. If you see this picture in purple, this purple area coming here, these are ligaments that hold this capsule in place. And the cavity here, this fibrous capsule, is filled with synovial fluid. The end of these bones, again, we don't want to see bone on bone. We have what's called hyaline articular cartilage. And I kind of describe this as a really smooth area, kind of like when you have a drumstick. At the end of the drumstick, if you ever take the bone apart, you have a really smooth area. That's considered the hyaline articular cartilage. And again, as we get older, um, with a lot of wear and tear in our body, we begin to lose some of this joint space here, and we end up with osteoarthritis. So because I said synovial joints are mainly found all over the body because of our limbs, we then need to classify the synovial joints by their movement type. So for example, if I want to refer to the synovial joints found in the carpals of the hand, then these would be considered plain or gliding, right? So there are some synovial sacs here, right, that allow kind of like a lubricant, right? But the movement here is mainly just plain or gliding. If we look at our fingers, our digits, right, we have, uh, we can open and close our hand, right? This is called a ginglymus movement or a hinge, kind of like your elbow. If you flex your elbow and extend your elbow like a door, right? A hinge on a door. So we call these ginglymus movement. The other type of movement on synovial joints is called the trochoid or pivot movement. And this you can easily do if you extend your arm and you kind of rotate your hand um, up and down, right? The movement is considered trochoid or pivot. That's the type of movement we have there. And we also have synovial joints in this area as well. The one that they're showing here with C1 and C2, this is cervical 1, cervical 2. This is what allows us to move our tilt our head, rotate our head. We also have some synovial fluid in there as well. The other one that we see here is the ellipsoid, also known as condyloid type of joint. And that one you're going to find strictly here in the wrist area. I was telling the class, and I always remind the class, that if you take your hand and move your wrist, it's pretty flexible. It's diarthrodial, it has lots of movements. We actually have about 5 different movements that we can do with the wrist. We have abduction, adduction, flexion, extension, and circumduction. And you'll study about that some more as you're moving on to upper extremities. Um, and there's only 3 bones involved with the movement of the wrist. You have your radius, right, which is the bone right here, and then you have the lunate, and you have the lunate up here and the scaphoid as well. And those are the only 3 bones that comprise the wrist joint and allow for that ellipsoidal movement. Again, and we have synovial joint fluid in here. All right. The sellar or saddle joint movement is found in the first carpal metacarpal, which is your thumb. And as you can see, your thumb has more flexibility than the other digits on your hand. And that's because it has a sellar or saddle type of movement here. And you can see the saddle, right, on both ends, and they just kind of sit um, on there, kind of like a perfect match. And so we have, again, some synovial fluid here. So some people, you know, when they have an injury to their thumb and they swell up really bad and they can't move it as much, it's going to be here in this area. The other one, that type of movement, is called spheroidal, or ball and socket. And we only find it in two places. This is going to be in the shoulder joint, and this is going to be in the hip joint. And we call it a spheroidal movement because there's always a ball, right? Which the ball in this case would be the head of the shoulder. And then the socket is what we call the glenoid fossa. And so the movements on here, again, especially the shoulder, has a lot more movement than the hip. So it would be considered diathrodial. What type of diathrodial movement? Then we would classify it even more detailed by calling it a spheroidal movement, or ball and socket. We also have it in the hip area, the head of the femur, which is right here, and then you have your acetabulum. When they come together, it kind of hugs it, snugs in there. The hip joint is, or the hip, the hip joint doesn't have as much movement as the shoulder joint, but it does give us quite a bit of movement. The acetabulum, I was explaining to the class, is a lot deeper than the glenoid fossa over here. And that's for a good reason, because most of our weight is carried in the lower back and the hip area. So we don't want the femur to come out of the socket, right? So we have this spheroidal joint, both again in the hip and shoulder joint. This last one that we're looking at is called the bicondylar movement. And this is because on our knees, we have two condyles. We have a lateral condyle and a medial condyle towards the end of the femur. And really with the knee, we can only either flex it or extend it, right? With the temporomandibular joints, we also have condyles that help us to open and close our mouth, right? So because both condyles are moving at the same time, one on the left, one on the right, again, bi means two. So both condyles are moving at the same time. So it's called bicondylar movement. And again, we have synovial fluid capsules found in these areas. So when there's injury or inflammation, of course, the patient won't have that lubricant, won't have that ability to move that joint. So they have difficulty opening their mouth, or perhaps walking with their knees, right? They might have swelling. So again, just sort of going back, talking about synovial joints, the movement types, these are the ones that you need to be familiar with. They're either planar gliding, ganglymus, hinge, trochoid, pivot, ellipsoid, also known as condyloid, sellar, saddle, spheroidal, ball and socket, and then bicondylar. And at least remember where these joints can be found, right? The movement, right? For example, planar gliding, we know that they contain synovial fluid, they're synovial joints, and we're talking about the carpal bones. We're talking about the shoulder blade is also planar gliding. Ganglymus, we're talking about digits, right? Phalanges of the hand, elbow would be ganglymus. Trochoid would be the forearm where we can pivot, right? We can turn it side to side. Also, the C1 and C2 was another example they gave us. Ellipsoid, again, belongs to the wrist joint. Ellipsoid has lots of movements. I told you that one has 5 different types of movements, also known as condyloid. Sellar, strictly just to the thumb, right? It's about the only place where we can have that type of joint movement. Spheroidal, ball and socket, the one that we just went over, only belongs to shoulder and hip. And then the last one, of course, bicondylar, belongs to the knee, and then up in the mandible, mandibular joints with the temporomandibular joints, where we have condyles. The next one is this section here uh, is looking at the different body habitus. The body habitus is generally defined as the build, the physique, and the general shape of the human body. And as you can see, you have hyperstenic, stenic, hypostenic, and astenic. Okay, and as you can see, the average patient, your average patient, Bontrager says that 50% of your patients will be considered stenic, right? And this would be the typical patient, regular sized patient. As your patient gets bigger, perhaps obese, we consider that patient a hyperstenic patient. And they're saying that, again, massive, and this is about your 5% of the population. Hypostenic would be somebody that's slender and falls in the 35 percentile. And then your astenic would be a really slim, tall patient, right? Really long torso, falls about 10%. Now, understand that the reason why we need to understand the body habitus is because if you look at these pictures, their lungs change in their location. You know, as you're wider, hyperstenic, you see that these are running more, that your lungs are wider rather than longer. The stomach is sitting more longitudinal than vertical, right? So things tend to move up a little bit more. In the astenic, the very slender, you can see that the lungs are a lot longer. The stomach runs more vertical rather than horizontal, and so do the intestines. See the intestines here? And so knowing the patients and being able to identify our patient's body habitus is going to help us when we uh, begin to position our patient, especially when we're talking about the orientation of the image receptor. We either want portrait or we want landscape. So I was giving an example to students in class that if you are doing a chest x-ray, for example, on a astenic patient, you would want to do it portrait because it would cover, you would try to cover the long lungs on this particular patient. But if you look over here on this hyperstenic patient, then we would probably want to use a landscape because his lungs would be wider this way rather than lengthwise. And so we would want to make sure that we include all the lungs on there. Alrighty, that's the end of this part of chapter 1. I'm on page 15 in your Bontrager. And for week 3, I'm going to upload another video that I already have. And that way you can review as well before you come into class on Tuesday.